Here. Share the screen. And then I need to open the cases. So is my screen now shown, people, doctors?
Yeah,
Can you see my
we can
screen?
see.
Yes.
You
Yes, we
can
can
see.
see.
Good, good. Okay, I will open the 3 minutes. Okay. So Dr. Rizwana,
Yes,
you are here?
yes.
Okay, so I will give you, so you can see a picture and there's a lot of reading down there. I will
Mm-hmm,
start the 3 minutes, and when you
mm-hmm,
read the first bit, just tell me to scroll it down so you can read what is there.
mm-hmm.
Okay, and then after the 3 minutes, we will discuss what your thoughts was in the 3 minutes, because as I'm saying, these 3 minutes is the golden 3 minutes. Okay, um, don't waste it in nothing. Okay, you need to use them in thinking what might be going on and what your plan is. And usually, if you prepare your thoughts well in these 3 minutes, most probably we will perform very well in the case. If you didn't use it properly, okay, your performance will be a little bit not as perfect as you would like. Okay, so after the 3 minutes, I will discuss with you what your thought was and what you are thinking in, and I will tell you what me myself would think in such situation. Maybe you will learn something from the way I'm thinking. Okay.
Mm-hmm. Yeah, sure.
Yeah, so I will open the 3 minutes.
Can you scroll down, please?
Is there was any problem in seeing the cases? Doctors, are
Doctor,
you
why
seeing?
can't I see it?
You cannot see it?
No.
We can. Oh, sorry, Salim. I can see it. I can see the picture in one side and the timer is going on other side
So
on
so
your
you
screen.
can see it. So most probably
Yeah.
doctors say that think then the problem from your side.
Should I
Double
log
check.
off and come back again?
Yeah, no problem. You
Thank you.
can. Yeah, no.
Sorry, Salim. By looking at the picture,
Mhm. Your 3 minutes didn't left yet. Don't waste them.
okay.
Yeah, you concentrate on the, yeah, so looking at the picture, yeah, what you think about it. Yeah, so what you think?
if I'm honest with you, by looking at picture, I'm not entirely sure what it is, but my differentials will be like one thing is probably like joint issues to ruled out,
Okay,
and
okay,
then skin disease,
okay.
and then
That's
patient
good.
is diabetic. I'm just thinking
Okay.
like, so these three is my main differentials at this point. Any joint issues, any skin related issue, if anything
Yeah,
related to
yeah,
diabetes and nerve related
which
issues.
both of them related, isn't it? So if the
Mm,
joint is inflamed, the skin will be inflamed,
mm-hmm.
most probably.
Yeah. Mm-hmm.
Okay, and then but you can understand if there is problem in the joint or the skin from the complaint, foot pain.
Mm-hmm.
I'm not aware about anything in the skin will cause pain except
Mm-hmm.
of herpes something, herpes zoster, herpes simplex, can cause pain if with the skin infection.
Mm-hmm.
Yeah, but cellulitis could be, but it will not be scattered like that, isn't
Scattered.
it? So this
Yeah.
will be a sheet of inflammation. So
Mm-hmm.
most probably this patient coming of joint pain or trauma or something
Mm-hmm.
related to his diabetes. And most
Mm-hmm.
probably if he's a patient with diabetes and insulin, so this is something related to the joints or blood vessels. But blood vessels wise, most probably he's a healthy skin, isn't it? So you can see the
Mm-hmm.
hair there, which is
Mm-hmm.
very rare in diabetic patients with uncontrolled diabetes to find hair at the dorsum of the foot or the chin of his leg. Usually the hair will fall down because of, the ischemia that's happening to the blood vessels. And
Mm-hmm.
you can see the skin more or less healthy. So less
Mm-hmm.
likely to be skin problem related to diabetes.
Mm-hmm.
You can see his toes are healthier
Mm-hmm.
thingy. Yeah, you cannot see any changes in the nails, which usually in the diabetic patient, the nails will be changed. So from just looking at the picture, there is a lot of things can come to your mind. Okay.
Mm-hmm.
We cannot see scratch mark, so most probably is not eczema, isn't it? If
Mm-hmm.
eczema, there
Mm-hmm.
will be scratch mark. And
Mm-hmm.
then coming to his other bits, what you can think in here.
His BMI is high. That
High, so this is
yeah.
something you need to write in your, so there is no single information giving in the data will not be used either in
Mm-hmm.
your real life, either in the exam.
Mm-hmm.
Okay, so if there is an info given by an examiner, so he must probably want you to use it in your management or in your info, on your data gathering. So BMI here you should circle it in your whiteboard and
Mm-hmm.
write it there that you need to address the BMI.
Mm-hmm.
Okay, even if it's not related to the complaint, it's there. So the
Mm-hmm.
so you must use it. And the examiner
Yeah.
for sure had a point for it for the candidate
Mm-hmm.
who will address it, and the candidate who will not address it will be marked a little bit lower. Okay.
Mm-hmm.
Um then coming back to the meds, do you see any discrepancy or something you may try to discuss with the patient without knowing his complaint and existing complaint and addressing the existing complaint. Is there any discrepancy you may or may not find in such medications? Think. It's important.
Sorry, medication wise, I'm not
Yeah.
entirely sure. I was just thinking if anything related to gout by any chance, then that's thiazide like
Yeah.
diuretics, basically.
Yeah, this is one. Yeah, excellent. And the other thing, again, related to thiazide, furosemide is not thiazide. Don't make me.
Yeah, that's what.
Yeah, it's
Yeah,
furosemide, not thiazide. Furosemide is a
yeah.
loop diuretics, okay? Thiazide
Mm-hmm.
is different, okay?
Mm-hmm.
So furosemide is a loop diuretic. So he's in loop diuretic. Well, if
Mm-hmm.
it's gout, it might be related to it.
Mm-hmm.
Okay, might not. Uh, if he's complaining of pain, it might be related to gout. But the other thing, you can see, there is furosemide, but there is no other medication that may be used for heart failure, isn't it?
Okay, yeah. Mm-hmm.
So, yeah. So
So your question is it actually necessary?
yeah, exactly. So why furosemide? Because the
Okay.
problem is with the all the practice, okay,
Mm-hmm.
from 20 years ago, we used to give furosemide for every patient have lower limb edema or leg
Mm-hmm.
swelling.
Mm-hmm.
Gravity related, heart failure related, just give them furosemide. Okay, well, is this furosemide is indicated in this case or not? Does this patient has a heart failure or not?
Mm-hmm.
So this is a question, the second question you need to consider it if you have time in the management. Okay,
Mm-hmm.
this
Yeah.
will be an extra point. Okay, it's just you need to address the ice. The main, this is which is the
Mm-hmm.
main concern of the patient. But these points you can put them aside if you got time and you are not
Mm-hmm.
running out of time. You may
Mm-hmm.
discuss it with the patient.
Mm-hmm.
Okay.
Yeah.
And then the other thing will make me also curious, but well, this patient in metformin and then they jump to insulin.
Insulin.
Yeah, so there is nothing in between metformin insulin directly. Well, usually I would question that.
Mm-hmm.
Is it related, not related? Also, this is something you need to, to think about it. And if it's related to the case, you may, consider asking, few questions regarding it. Okay. This is how me personally would use the 3 minutes and thinking. Okay.
Mm-hmm. Mm-hmm.
Um, is that clear?
Yeah.
Yeah, you know that the steps, how, type 2 diabetes, how we are stepping wise the things.
Yes.
Y- So tell me. You said yes,
So,
so tell me. Yeah.
so type 2 diabetes, the first management will be like lifestyle management, diet controlled.
Mhm,
If HbA1c target more than 48, 48 is our target. If patient has HbA1c more than 48, then the first we will start with metformin. Um, then if patient is on metformin one medication, then the target will be if a patient HbA1c 53, then we
mhm.
need to think about adding second medication. Uh,
Mm.
at that point, we need to consider, as an example, if anyone is having heart failure, CKD,
Mhm.
then usually like dapagliflozin and pagliflozin will be the choice.
So this is as an additional.
If
So
like HbA1c is more than 53, then we will add the second medication.
are you sure? Any other thoughts around? So yeah, so the new guidance, which is from I think 2 years now. So the first, yeah, for sure, lifestyle modification is you need to address it. It's the core and management of diabetes, hypertension, and other metabolic syndromes. For diabetes, yeah, metformin is the first line therapy, but surprisingly, dual treatment metformin dapagliflozin is also considered to be first line therapy for patients having Q risk more than 10. So if this patient have a Q risk, high Q risk, why he was not started in dapagliflozin? Okay, so this is a potential, question mark. You may consider it. Okay, so dapagliflozin is not an add-on therapy for patient having heart failure or hypercholesterolemia, dyslipidemia. If the patient from the start having age more than 40 and his Q risk is more than 10, you must start him on metformin plus dapagliflozin as first line therapy. Don't wait until you see if his hemoglobin A1C will go below 53 or stay above 48. Okay. So there is something called metabolic resilience, which stated that the more aggressive treatment of the metabolic syndrome like diabetes, the earlier you start to treat, the easier to control. So if the patient have a high risk, so there is something called metabolic memory. So if the cells having persistent high hyperglycemia for long term, she will consider the hyperglycemia as a norm, and you will suffer just to try to decrease the sugar of this patient because he may get hypo very easily. Okay, so if the patient have a having a high risk patient with Q risk more than 10, so you need to start the treatment aggressively. Okay, and you need to try to start the metformin plus dapagliflozin for sure, not in the same setting because you don't want. My advice: don't start two meds at the same time. Okay, but this will be the first line therapy and you will start it gradually over a month or so. So me personally, I'm giving them, okay, metformin, start the metformin, one tablet in the first week, okay, after the main meal or in between the main meal, okay, during the meal. And then the second week starts two tablets metformin, okay. And then the third week, please, if you didn't experience any side effects from the metformin, then start the dapagliflozin 10 milligram in the morning. And then after that, by another week, in the fourth week, then take the three tablets of the metformin and the one tablet of dapagliflozin. So after a month, you already established the patient on the two medication. Okay, and
Okay.
it's gradual. So gradual, then if any side effects happen or any, any annoyance from the patient that he's not happy with one of the medication, you will be able to pick it up. So if you have experienced any GI symptoms from metformin, then you can transfer him to the sustained release. Okay. If you had
Mhm.
any infection from the dapagliflozin, then you can address that. So if you have frequent UTIs or frequent or thrush, then you need just to, self management, how he need to clean himself more frequently, take care of the self hygiene, and then see how he will go with it. And well, if he is happy with it, then continue. If not, then we may consider another treatment. But then metformin directly insulin, this is questionable. So for sure there is some missing point there. You may consider asking about it if the if the complaint related, but then if the complaint not related, it's just you need how this is how you should think in real life cases. Okay,
Mhm.
shall
Yeah,
we,
sure.
is it clear or there is any question up till now from the audience?
Yes, it's
Hello,
clear. Thank you.
clear?
Yeah.
Yeah, that's fine. Okay. So shall we start, Rizwana?
Yeah, sure.
Yeah, I hope I didn't make you confused.
No, no.
No? Okay, okay, because sometimes deep thinking can make the things worse, not, not clear. So, but this is how I'm thinking. So, yeah,
Okay.
yeah, yeah. Shall we start?
Yeah, sure.
Yeah,
Hi, I'm Rizwana, one of the doctors from GP surgery. Am I
yeah,
speaking to Jack White?
yeah, doctor, I am.
Hi, Jack. Could you please confirm your age?
Yeah, I'm 55, doctor.
Jack, I believe our today's consultation is to discuss your foot pain.
Yeah, exactly. Thank you, doctor. Thank you for calling me.
Uh, Thank you for sharing the picture. Is it okay if you tell me a bit more details regarding your foot pain?
Yeah, to be honest, doctor, it started yesterday, well, all of the sudden, and then started in my little pinky toe, which is weird little bit. But since then, I can't even wear my shoes. Otherwise, I would
Mm,
come, but they offer me to come
okay,
to be examined, but then I really
okay.
cannot wear my shoes. So I said, I'm sorry if the doctor can just call me. So please accept
Mhm.
my apology that I didn't come. I didn't mean to be rude.
Absolutely fine. Don't worry. I could hear from your tone that the pain started from yesterday and it's quite bothersome for you.
It is really.
Okay, okay. Can you tell me a bit more about this pain?
Yeah, well, yeah, what you want to know, doctor?
So you said the pain started from your little toe. So on picture, I could see that your some other toes also look quite red.
Oh yeah, no, so sorry, stupid me. Yeah, that's no, I well, usually when I have pain in my toe, usually I'm using cold hot compresses. This is the other red mark is because of the hot water bottle. Okay, so they,
Okay,
they just burn my big toe on the other one, but my main pain is on the little toe there. So
okay.
yeah, the
Mm-hmm.
pain is there. The other marks are just I think from the heat, not anything else.
Okay, okay. So, have you tried anything else other than this hot and cold compression?
Yeah, yeah. Well, usually when I have such pain, doctor, I'm taking ibuprofen. Even I
Mm-hmm,
got some naproxen from my wife medicine,
mm-hmm.
but nothing helped. Well, I'm not sure. Yeah.
Okay. So you told me, Jack, you told me that when you have pain, that means you had this pain before?
Yeah, yeah, doctor. I'm not sure if it's not written in your notes there. Yeah, I used to have gout. Okay,
Mm-hmm.
but
Okay.
it's usually coming to my big toe. I'm not sure why it's coming to the little one. It's the same pain, to be honest, doctor.
Mm-hmm,
The same
mm-hmm,
pain. Also, I cannot wear
mm-hmm.
my shoe, so it's the same
Okay.
pain. And usually the doctor
Mm-hmm,
giving me a tablet with C thingy. Yeah, it started
mm-hmm.
with C. Yeah, and
Is it
usually it's kill.
colchicine?
Yeah, yeah, excellent, doctor. Yeah, thank you. Yeah, you
Okay.
are brilliant. Yeah,
Okay.
yeah, this is the
Oh,
one.
thank you.
So this
Okay.
one that they are giving it to me, and
Mm-hmm,
usually it will cure my pain, and
mm-hmm,
then well, and
mm-hmm.
that's it. Usually with the second day, yeah.
Okay. Okay. So, just give me an idea how many times this pain happened in the past.
Well, it's been a while. 2, 3
Mm-hmm,
months ago, I didn't have any pain, but then, well, before that, I was having them maybe every 2 months or so.
mm-hmm. Okay.
Yeah.
So other than giving you colchicine, did anyone discuss any other pain medication by any chance?
No, no, no.
Mm-hmm.
They are
Okay.
usually they are, the doctor's telling me off if I take,
Mm-hmm. Mm-hmm.
naproxen or ibuprofen because they're telling
Okay.
me, oh, this will kill your kidneys, but the pain is pain there. Well,
Mm-hmm.
so I need to take them. I can't live with the pain.
Okay. Okay. So when we were talking about like kidney function, it was discussed in the past. Do you remember what was your last blood test results, but your kidney function test?
No, but they told me it's like, just on the edge. They told me like
Okay.
that. Yeah. But
Mm-hmm.
I'm weighing fine, doctor. Don't bother.
Okay.
Some
Okay.
doctors like
Mm-hmm.
to make a big fuzz.
Okay, okay. So, Jack, few more questions just to understand your pain better. Okay, do
Yeah.
you have any pain, any other joints at all?
No?
Okay, you said putting shoes quite difficult. Are you able to weight bear on that joint?
Well, yeah, wood bearing is fine.
Mm-hmm.
I'm able to tilt my leg a little bit, but the problem is
Okay.
I can't wear the
Mm-hmm.
shoe.
Okay, okay. So, any rush anywhere in your body other than that area?
No,
Any pins and needles on the foot?
no.
Mm-hmm. Any stiffness at all?
Well, yeah, just in the beginning when I wake up in the morning, it will be
Mm-hmm.
stiff little bit, but then later on it's fine.
Mm-hmm. Anything particularly that you could think of triggering your pain?
Well, triggering my pain, I think it's the inflammation in my joint. I
Mm-hmm.
guess so. Yeah.
Okay, so few lifestyle questions could contribute to that pain.
Hmm.
Do you drink alcohol?
Oh, yeah. You came in and you will just tell me stop. Well, to be honest, doctor, every week I'm drinking my whiskey. Okay.
Mm-hmm.
I can't get rid of my whiskey. I need to drink at one bottle over the weekend.
Mm-hmm.
And then during the weekdays because of the work I'm drinking my red wine.
Mm-hmm.
Yeah, so it's to be honest, I'm not counting how much. So yeah.
Mm-hmm. Mm-hmm.
God knows,
Uh,
doctor. God knows.
mhm. Do you think you are drinking more than 14 units of recommended
Yeah,
level?
sure, without doubt. Yeah, but
Okay.
again, I like my
Mm-hmm.
alcohol. Yeah.
Mm-hmm. Okay. Okay. By
But
any chance
and
you?
and I'm been drinking like that, ages. So I
Mm-hmm.
don't think it's related to my toe at all.
Okay. Okay. So you told me that you were thinking about gout. Anything else going on in your mind?
No, no, to be honest, I don't think so.
Mm-hmm.
I didn't hit it. I didn't have a trauma. I'm cautious about that
Mm-hmm.
because of my diabetes. I'm always having the foot check and the eye
Mm-hmm.
check, and they are telling me it's fine.
Okay.
So I don't think there's any other thing. Generally, I'm
Mm-hmm.
fine. I don't have any temperature. I think also there's
Okay.
an infection or something, but no, everything
Mm-hmm.
was okay-ish.
Oh, that's quite a sensible thought, and you gave me lots of important information. Other than colchicine, anything else that I could help you today?
Well, no, I think maybe that just the colchicine and I will be
Mhm.
happy with that.
Okay. So after talking to you, Jack, I'm also agreed it could be another attack of another flare up of your gout.
Mhm.
Okay. So do you think I will be able to examine you? You said quite difficult for you to come
No, I
to
will not be
GP.
able to come, doctor. I can't, I
Mhm,
can't walk without,
mhm.
barefoot. I can't. And then
Okay.
who will drive? I
Mhm,
cannot drive.
mm.
My wife now is in
Oh,
Spain, enjoying in
mhm,
Spain, so I don't have
mhm.
anyone to drive me.
Okay. So I could see that it's quite affecting your day-to-day life. Okay. So
Well,
let's
not
discuss
much, just the pain. I need the pain to go away.
definitely. Let's talk about your pain medication first. Okay. So I'm happy to prescribe colchicine. Okay.
Okay.
You know that this helps with the flare up. Okay.
Mhm.
So I will prescribe 12 tablets. So I believe you already tried that before. So you could take one tablet up to
Mhm.
4 times a day. Okay.
Mhm.
Based on your pain level. So
Mhm.
whenever like you will finish these 12 tablets, book another appointment so that I could catch up. How are you doing? Is it okay?
It's just I'm not clearly understanding. So the one tablet 4 times a day and
Up to
finish the
four
12
times a day.
tab. What you mean by up to?
So by saying like you could take this tablet every 6 hourly, okay,
Mm-hmm. Mm-hmm.
uh, 4 times a day, okay. If your pain is well controlled with three medication, that should be fine as well, okay.
Mm-hmm. Okay, so
So
you mean that I will take the tablet if I have pain, but if I don't
I
have pain,
mhm,
I should not take it. Is this
mhm.
what are you saying?
I would say at the moment your pain is quite bad at the moment, okay. So take this medication at least like 3 to 4 times a day, okay. The
That's
reason I
fine.
mentioned that I will prescribe 12 tablets, whenever you will finish this 12 tablets course, after that we need to give at least 3 days back if we want to repeat the prescription. And that's why it's so important. And I'm telling you why I'm prescribing 12 tablets at the moment. Is that clear so far?
Yeah, it's clear, but then if you prescribe me just more, maybe I will keep them aside. So if I have another flare up, I will not call you
Mhm.
and bother you.
Okay.
I mean, I would pay for the 12 tablets the same amount that I will pay for the 100 tablets. So
Okay.
would you
Okay.
prescribe for me the 100? Because this is what your colleague was doing for me from before.
Okay.
They prescribed me the
Okay.
100 tablet. I will pay 10, 10 quid
Mhm.
for
Okay.
12 tablets only, doctor. Yeah, give me that
Okay.
100 tablets.
Okay. So, Jack, it's so important. This medication has overdose, so has high chance of overdose. Okay, so
Mm-hmm,
after 12 tablets we need to make sure that there is 3 days back.
mm-hmm,
However, I do consider about your like you need to talk about long-term management plan. So you are having this gout quite frequently. We need to put you on another medication called allopurinol, so to prevent further flare up. You will be on allopurinol for longer time. We will very slowly building it up to see which level is good for you. Would you like to consider that medication when your flare up will be
yeah,
settled?
but you are the only doctor who told me about that. I mean, all your colleagues from before, no one told me that I need to take the long-term therapy. Oh,
Okay.
and
No,
why it's needed, doctor? Why I should take the long-term therapy?
I apologize that we have not explained it before. So the recent guideline is saying if anyone is having attack of gout more than one time, then we need to start them on long-term prevention. Also, it's really important to talk to you about your alcohol drinking because it's very known to flare up your condition. How much do you think you will be able to changes your alcohol drinking? Will you be able to
Well,
cut down?
no, to be honest, I'm not open to decrease my alcohol drinking. I'm fine with my alcohol. It's just I'm not getting why I need to take the long-term therapy treatment.
Okay, so this long-term treatment to prevent further flare-up of gout, and your colchicine will give you relief for the time being. I'm really sorry, Jack, I'm running out of time today, but I would like to do another catch-up, probably like 5 days time,
Yeah,
just
that's
to know
fine,
how you are
doctor.
doing, if your pain has been settled. And at
Yeah,
that
yeah.
point, do you think it's a good idea to discuss more about your allopurinol and lifestyle?
Sure,
Thank you.
no problem, doctor, no problem.
I don't know what
Okay.
I'm doing.
No, you did fine. You did fine. But the issue is, I think we don't know the concept behind the treatment. That's only. That's why I intend to give you the question. And you might have someone questioning you why you want to treat me long term. You know, I'm already in three, four medication there. Why you want to put me in
Mhm.
another fifth medication? Well, for you as a prescription, for the patient is a tablet that he will take. And who knows if the patient's eager to take tablets or not, or compliant or not, having difficulty in swallowing or not. Now, what past experience he had from medication, and every medication is a potential side effects. So you are giving him medication that may make him having side effect. Allopurinol, can kill, by the way. Allopurinol can cause severe hypersensitivity, Steven Johnson syndrome, and you can die from simple tablet like allopurinol. Okay. You know Steven Johnson, yeah?
Yeah.
Okay, so Steven Johnson is one of the side effects of the allopurinol. So if you will prescribe the patient a medication, he needs to know why you are prescribing it to him. Otherwise, if he got the complication, which is rare, but then you are the one to be blamed. You write it, you didn't educate the patient, and the patient most probably will say, "Oh, the doctor forced me to do that. He's the doctor, so I just follow his advice." But really, I don't know why I need to take the allopurinol. Okay, that's fine, preventing the flare up. No, so I'm taking colchicine, and the flare up is cleared within the second day. So what is
Mhm.
the problem for me taking the colchicine every time? We'll discuss that, no problem. So in the beginning, I like your opening. Okay, you did use the pre-existing information, but then again, the problem is with what you are saying. Can you tell me more? And then I block it. Okay, what you want to know? I don't know. Sometimes this phrase is not, is not showing that you know what you're asking about. So you may try to avoid it, except if you don't have any other phrases. Okay, so can you take me through your pains? Can you take me through the episode? How this time started? Is it different from the first time? And how is different? Okay. But can you tell me more? He can block it. Okay, what you want
Okay.
to know about it, and then what you want, then you will tell him, then you will answer him with another closed question, and then you keep, losing your time. And this is the problem
Mhm.
with can you tell me more? Okay.
Mhm.
You know the difference between closed and open question, isn't it?
Yes, yeah.
So what is the difference?
As an example, when initially I said, tell me more about your foot pain, that was open question.
Yes,
And then I
yes.
started asking about when pain started. So that's
Exactly.
close.
So usually the WH question is a closed question because, the answer will be certain and specific. Okay.
Mhm.
Any non-WH question usually will be an open question, and the answer will be a story like without closed specific answer. Okay, like how it started. Take me through the episode from the beginning, and you are telling him, tell me story exactly. So this is what the beginning of the consultation should be, and then after one or two, after 2 minutes, 3 minutes time, then this is the time of asking close the question because you already know the story. You have a good understanding in these 2 3 minutes. You have the differential, and you need to proceed to your closed question, closed medical questions, to just narrow down your differential. Okay. I like that you ask about other joints, you ask about stiffness, you ask about rash. Uh, is there anything else you would ask about it?
Yeah, I missed fever. So you told me about fever.
Fever,
That
yeah,
was
yeah,
important. Yeah.
yeah. Well,
Then you told me about trauma as well by yourself.
yeah. So these are the things that you need to ask. This is one. The other thing,
Mhm.
is it, with any case with arthritis, yeah, it is considered as, type of arthritis for sure. Is the gout. You need to know, is it reactive arthritis, or it's inflammatory arthritis or non-inflammatory arthritis. Okay, which you touch base on it. Well, you have a stiffness, but then I volunteered at the stiffness in the morning and it's going that, after a few minutes from, from starting waking up. But these things need to be explored. So I didn't hear that are you having a differential in your brain that is this is reactive or not reactive, or this is inflammatory or non-inflammatory arthritis. Okay? You
Mhm.
know the difference between them, isn't it? I will share the table showing the difference between inflammatory and non-inflammatory. I think also it's not unwise to ask him about any GI symptoms, okay, any,
Yeah.
STI symptoms, because these can,
Eye symptoms,
yeah,
yeah.
okay, can be reactive arthritis for chlamydia
Mhm.
STI or
Mhm.
Campylobacter gastroenteritis. So yeah, most probably it is gouty arthritis, but also you need to consider the other differential in your asking. Okay,
Yeah.
I would like to hear that the next time.
Mhm.
And the lifestyle, you did ask the ice. I don't have a problem with it. Uh, but in the lifestyle, you just ask about alcohol. So, is there anything else you would like to ask him? Especially,
Yeah,
he did
diet,
told you, yeah.
basically.
So, what exactly in the diet?
Mhm.
What exactly? Because this patient, when I asked him, he
Mhm.
had brawn in the last 2 days, and he ate like 1 or 2 kilos of prawns. So would it be the initiation for his symptoms? Most probably yes. Yeah, shrimps and seafoods are having high
Okay.
quantity of uric acid. So this is important.
Mhm.
So this need to be addressed in the patient education later on. Okay. Yeah, alcohol.
Okay.
Yeah, we just touched base on alcohol. You were aware that you are drinking more than we recommend. Yes, but I don't care, doctor. I want to keep drinking it. That's fine. It's totally up to you. But please, if if you wish to, or if you consider to stop drinking or want help with that, please, you can contact me. Okay, keeping in mind that alcohol is not only affecting your uric acid, but also affecting your heart, affecting your liver. Do a bit of education and see what he will say and
Yeah.
crack on. Yeah, you did say the issue is I didn't hear from you what is a gout is. So yeah,
Yeah, I
he
didn't
knows that he
understand.
have
Yeah.
gout, but then with every yeah, with every management plan, you should start with the diagnosis, okay, or introducing the ice, and then yeah, you use the ice. I will give you painkiller, but do you know what is gout is? Just for my curiosity. So then yeah, that's uric acid high or something like that. So high where? This is important. So if you will explain to patient what is gout, would you please volunteer and tell me what you will tell him?
Uric acid started building up on the joint and causing inflammation,
Okay,
pain, swelling.
then exactly, but then this will not make sense why you want long-term treatment.
Can I add?
Yeah, please.
Gout is a long-term condition which tends to flare from time to time. What happens is that the one of the chemical in the body called uric acid tends to accumulate and then build up in the joints, and then it affects the joint from time to time.
Okay, that's fine. But again, you are saying joint. Then what will happen if I didn't treat it? What will happen? Why I need to take the preventative therapy?
uh, because to prevent the flares.
Okay. So is the gout, doctors, is the gout is a systemic disease or is joint disease?
Systemic disease.
So I didn't hear that in your explanation. So you already know it.
Mm.
So Sayeda and Rizwana, you are there, yes, or you disappeared?
Yes, yeah.
Yeah, so well, gout is a systemic disease. Gout is part of the metabolic syndrome.
Mm.
Gout, as the uric acid crystal is building up in your joint, is building up in your other systems as well, building up in your blood vessels, building up in your kidneys. I saw people have renal failure because of gout, and the opposites. Gout, renal failure will cause high uric acid. So this is very important to be addressed to the patients. Okay, and even in real life, because this is very annoying because this is the everyday practice. I'm seeing patient having gout and they are not being treated with allopurinol, although they are indicated. This patient is very high risk patient. He have uncontrolled diabetes. He have hypertension. He is overweight and his BMI is 35. He's drinking massively. So he's like a walking bomb. He will just explode at any time. And he's adding that by not treating his gout. Gout is a systemic disease. Your as the crystals of the uric acid or the uric acid building up in your joint and causing inflammation and may cause destruction and deformity. Don't say destruction, will make permanent damage later on. Don't say destruction is a bad word, but say permanent damage. Okay, can cause a permanent damage at your joint as well as can cause damage to the other organs like your kidneys, like your heart, or like your blood vessels. It's not unwise to start to control it because maybe if we control the uric acid, your blood pressure will be better controlled. So that's the aim from long-term treatment of gout. Because it's systemic disease, it's not only a joint disease. Okay, and that's why I start to resist you. Well, why you want to put me in the allopurinol? Doesn't make sense for me. Okay, I have a flare-up. If the patient have osteoarthritis, would you give him a systemic control for osteoarthritis? Well, we can then invent that every patient with osteoarthritis, he should take prednisolone or corticosteroids to prevent, the flare-up of osteoarthritis. If the concept of the gout is just to prevent the flare-up. If patient with osteoarthritis take some, uh, preds low dose over long term, this will improve the joint pain. So are we prescribing for osteoarthritis prednisolone? We are not, because osteoarthritis is a pure joint disease, not a systemic disease. So you don't need to treat it with the systemic tablets. Is that clear, doctors?
Yes, it's clear now.
Yeah.
Yeah.
And it's very good to explain that to the patient, okay? So he will be eager to open up for you. And even if you start to explain that to him, he may reconsider stopping alcohol. He may consider listening to you because, oh, this doctor knows what he's doing, knows what he's talking about. And he do care about me. He doesn't want to just give me the painkillers and okay, go, this 10 minutes finished. I need to see the other piles of patient on my waiting list, okay? And then I
Yeah,
didn't
sure.
hear you addressing the frosimides because I think you run out of time. I know that you know that you
Yes.
the frosimide. And
Yeah.
then the other thing, this patient doesn't have any bloods. Yes, he's diabetic,
No, yeah.
hypertensive.
Mm,
There is no bloods. Okay, did you ask him? Did you
mhm.
have blood recently? He will tell you have blood from 1 month, 1 year ago. Let him, okay, please, we need blood test for you. We need to consider this, that, and then he will give you another question. So, okay, doctor, please add the uric acid on the blood tests. What you will say to him? If you will
The
do blood test for this patient, say tomorrow, you want to check his thing. If there's eager to check it, although I would check it after a month, and I will tell you
mhm,
why after a month. But if this patient, you told him, okay, tomorrow I will do blood test for you, would you
mhm.
do uric acid for this patient at this stage or not?
No, usually uric acid we need to do when flare up has been settled.
Yeah, why?
Sorry, I'm
Yeah,
not
why?
sure. Is it
Why?
for
Yeah, why?
maintenance?
Yeah, why am
Because in
I
the
so
flare, they
everything?
tend
So
to accumulate in the joint and the serum level would be low.
most probably. Yeah, most probably. Also, most probably, sometimes the uric acid will be high, but most probably in the flare up, the uric acid will be accumulated in the joint. So we don't intend to take it, in the acute flare up. Okay, we will take it after subsiding of the flare up by 4 to 6 weeks. Okay, to see how much is your baseline uric acid, and we will take it from there. Okay.
Yeah, sure.
Clear? Coming back to the colchicine, I didn't understand how is the dosing is, to be honest.
So colchicine we usually prescribed 12 tablets, isn't it,
Yeah,
for acute flare up?
yeah, yeah. I'm not against that, but how he should take it? What
So
does
is
it
it
mean up to 4 times a day?
so in a day they could take 4 tablets, isn't it? And
Depend
that's
on
three
what?
days course.
Yeah, depend on what?
Oh, sorry, I told you depend on pain threshold. So they should continue 4 tablets for 3 days.
No. What you said is right, but I feel that you are not you are not very sure about what are you saying. No, so you are you will take one tablet and assess your pain within 6 hours. If still you have pain, you will take the other tablet, and then after
Okay.
another 6 hours, if you still have pain, take another tablet, and then when the pain resolve, you may stop taking the tablets. Okay.
Okay.
Or if he started to have side effects, if he started to have nausea, vomiting, diarrhea, he need to stop the to stop the colchicine because it's making side effects. You don't need to finish the 12 tablet course, okay?
Okay.
And you should not take it more than 12 tablets because the potential side effects and the toxicity of the colchicine, okay? That's why we need 3 days off colchicine, and then we may consider, starting the colchicine again. And the other
Mhm.
thing, we need to revise the diagnosis because usually, if this gouty arthritis, it will respond to colchicine within 3 days. The 12 tablet course. If it didn't respond, you need to re-question your diagnosis. Okay. So
So,
these are the concepts behind why the prescribing is there, okay? And you need to understand it, okay? It's not
so
just
my
knowing.
follow-up needs to be like, is it in 3 days time or
No, well, not particularly. You can tell them, okay, we'll give you the tablet. If you didn't improve, come back to me. If you improve, that's fine. Then we need to see you after 6 weeks, or 4 weeks, so we can see your blood test, okay, and consider the long-term therapy treatment. And then we have the allopurinol, and you can then, tell him allopurinol. We are starting at 100 milligram, and then see you after a month and see how you are going with it. If you are fine, we may increase the dose after 6 weeks of seeing the level of the uric acid. And then you may tell him about what is the target level of the uric acid. Are you aware about the target level?
it's 360
Yeah, there is
and
two
they
schools.
have
So
two
if there
score,
is,
yeah,
yeah, two
300.
schools. No, not two score, two schools. The American school is treats to symptoms. The British school is treat to target. Okay, so the American school is saying treat the patient until his symptoms resolve and controlled. Okay, and then stay on the the lowest possible dose, which is 100 or 50 milligram. In the UK, is treat to target. So you have 360, which is most of the population will be 360, except if you still having tophaceous gout or still having deformity in the joint or still having flare up of joint on the 360, then you will aim up to the 300. Okay.
Yeah.
So yeah, so the other thing, if the patient coming, the indication of the long-term therapy according to the NICE guideline, if you have more than two flare-ups in 12-month time, or if you have comorbidities which is there in this patient, or I have chronic tophaceous gout or chronic deformity in the joint. And surprisingly, if the patient have tophaceous gout, and he start the treatment and this tophi doesn't have fibrosis around, they will notice that the tophi will be resolved. I have seen patient, I think from 2 years ago, with and he had massive tophi under his elbows and all of his knuckles. And after 6 weeks or 3 months, all this was gone with simple tablet allopurinol. All of this gone, and he's jumping from happiness. So you may make a big difference not only in the patient's physical life, but also cosmetically. You can make a big difference for such patients. Okay, but you need to know the science behind it. Okay, not just prescribing it. You need to know why you are prescribing it, because again, allopurinol is one of the tablet that can kill. So you need to justify and share management with the patient, share management. So all the treatment here about share management, and then exploring the health belief of the patient. Okay. I
Yeah,
hope
sure.
that clear.
Yeah, sure. Salim,
Yeah.
I'm really sorry. Thank you
Yeah,
so
yeah,
much
no,
for
it's
your
fine. It's
feedback.
fine. I know you
Yeah,
are late. I know you are late. You can
I'm
go.
so
Yeah.
sorry,
You
but
can
thank you
go, no
so much. It
problem.
was really useful.
No, it's fine. It's completely fine. And I think there is massive improvement. No, there's massive improvement. Keep the
Can
hard
I
Thank you,
work.
Salim.
can I please quickly ask, can you please
Yeah, sure.
repeat the explanation which incorporates like all the things which you have explained?
Which one
Like a
exactly?
phrase, like a phrase to say that gout
Okay.
is gout, which
Okay,
incorporates.
so yeah, so gout is a buildup of, uric acid, okay, which is crystals in your joint, but these crystals, as it's building up in your joint, is building up also in the other organs of your body and may cause a permanent damage. So it can make joint deformity, it can make kidney problems or kidney damage. It can make blood vessel damage because it's accumulating in the walls of your blood vessels as well. So this is what you want.
Exactly. Thank you.
Yeah, yeah. And then I will share the PowerPoint of the gout. Let's go through it maybe rapidly, and then we'll head off to the second case. So I think this is the gout. Yeah, so this is 1A4 of management of gout. You have what is the options: colchicine, non-steroidal, or corticosteroid. Steroid. Does anyone know what is the dose of the steroid for treatment of gouty arthritis?
It's 30 to 30 milligrams once a day
Up
for five
to,
days.
yeah, yeah, up
Up
to
to
30 or 35. You may even start 10 milligrams and see what is the response of the patient on. So yeah, it's up to 35. If it's not responding to 35, you need to reconsider what is the diagnosis is, okay? Non-steroidal, usually naproxen will be fine. Okay. Is electroxib or alcoxia? Well, there is questioning about using the COX-2 inhibitor, so don't write it in the exam or don't prescribe it for such cases. Septic arthritis, very important to be excluded, and we said a little bit of the differential diagnosis, and then I think this A4 is very good. And then when you need to refer, okay, this is also an important. Be be cautious about the EGFR of the patient because it might appear in the exam with the patient having chronic kidney failure. So we need to know if the creatinine clearance is less than 10, which usually in our day-to-day practice, we are not using the creatinine clearance. We use the estimated EGFR. But if the EGFR is very low, you need to review the dosing of the colchicine and the allopurinol as well. Okay. In starting the long-term therapy treatment is also tricky and important. So if you will start the allopurinol after the acute attack, you need to cover it with colchicine or non-steroidal for at least 6 months. Okay, with different doses. So colchicine in the long-term therapy, you use it once or twice a day, just to prevent, to prevent the flare-up. Because when you are starting to absorb the uric acid crystals from the joint may flare up and show signs of inflammation. So colchicine will suppress the inflammatory process. Okay. I will share the PowerPoints. Okay, you will find detailed information about the dosing and the AGFR and most of the needed information regarding gout. Okay, gout is very common in our day-to-day practice. So it may appear in any exam related to the GP practice. Again, spironolactone is one of the things that related to the gouty attack. Oh, sorry, the diuretics in general. Beta blocker ACE and non-losartan ARPs. You need to consider that non-losartan ARPs. Okay, so losartan is the only ARPs that not directly uh, increasing the flare-ups, and the calcium channel blockers. So if the patient is on ACE or beta blocker or diuretic, you may consider, switching it to any other medication like for sure amlodipine. Is that clear up till now?
Yes, thank you.
Yes, yes, I am hearing only Dr. Mariam. The rest are sleepy. We become nine only. The rest run. Doctors, are you with me or most of you sleepy? I will just stop the recording for the first case. You will have them case by case, right, like that.